It's going to be really fluid in terms of, discussion and spaces. Dr. Wallace, I think you indicated before that you're happy sort of taking questions as we go. Is that correct? Or would you rather me wait until the end?
No, that's fine.
Mm-hmm.
Yeah, that's fine.
Okay.
I'll allow you to lead. I'll follow your lead.
Say that one more time, I'm sorry.
I'll follow your lead.
Okay, great. And I'll choose when that might be the best time for those to come in and that. Okay. Shall we launch? Are we ready?
Yeah.
Are we all together here? Okay. Welcome, everybody. We're so pleased to have you here today, and we're very lucky to have Dr. LeShonda Wallace with us as part of our speaker series. If you haven't already, please take a moment and fill out the survey that is in the chat box. So before we get started, I would like to thank some of the people who made this event possible. Sean Bingham, Bill Alexander, Nathan Crow, Stephanie Camille, Nikki Crucial, Kat Donkhouse, Elizabeth Taylor, Undergraduate Studies, and Paul Townsend. I am Dr. Michaela Howells, an assistant professor of anthropology. I'm delighted to be one of the organizers for the Pandemics Exposed lecture series, which you're taking part in today. This lecture series is a collaboration between UNCW Honors College, the Department of Anthropology, History, and Biology. Our goal in this series is to explore the biological, cultural, and historical frameworks surrounding pandemics to help us examine this extraordinary time that we are living in today. Today, we are so happy to welcome Dr. LeShonda Wallace. Dr. Wallace is a family nurse practitioner and the founder and executive director of Seeds of Healing. The goals of Seeds of Healing are to eliminate disparities in HIV outcomes for women, improve the quality of care received, reduce the number of new HIV infections, and minimize stigma associated with HIV. They achieve their mission with community collaboration for HIV awareness activities that promote HIV prevention and work directly with clients to provide health coaching. In addition to her transformative work with Seeds of Healing, Dr. Wallace is an active member of our community. She serves on multiple leadership positions, including as a board member on the New Hanover County Health and Human Services Board, Gen X Community Science Advisory, the Frank Harr Foundation, and New Hanover County's Resiliency Task Force, just to name a few. In addition, she's also the chair of the New Hanover County's NAACP Health Committee, who does tremendous work. As a medical professional and patient advocate, Dr. Wallace strives to break cultural, religious, and moral barriers that affect people's access to care. We are thankful she can join us today and share her work. So welcome, Dr. Wallace.
Thank you for having us all here together. So I want to just commend you, Dr. Howell, for allowing this opportunity to not only talk about a topic that is non-traditional in the sense of, as a public health clinician, when we talk about disparities in health circumstances, you usually hear us talk about cancers, diabetes, hypertension, even obesity. But to talk about HIV and AIDS on this platform where we can increase our new learners as well as our community, it is a change. It is an opportunity to have impact. And on behalf of Seeds of Healing, I just want to say that we are grateful to you and UNCW for this opportunity. I do have some disclosures. As the director of Seeds of Healing, I'm also one of the principal investigators for Gilead's COMPASS initiative. COMPASS stands for Commitment to Partnership in Addressing HIV and AIDS in the Southern States. And along with my colleagues, we are creating through our research a platform that will be named Soul Time, which is a virtual support for Black women who are living positively. In our discussion today, I hope that what you will be able to take away from this, you will have more understanding of Seeds of Healing role in the community. You'll have an increased knowledge about HIV. Hopefully, if there's any stigma that anyone may have, they may not even be aware of, that there will be a reduction. So you will have the opportunity to do a pre-survey, which I believe is in the chat box. And then towards the end, we can reassess. We will also expose the impact that COVID-19 has had on the Southern sisters who are living positively, and this is women who are living with HIV, and identify some strategies to ending the HIV epidemic. Now, I want to give you some background about Seeds of Healing. Seeds of Healing actually stands for Sustaining Empowerment by Educating and Developing Sisters. We were established in 2016, and I know, I believe, Dr. Howell, you already mentioned our mission, but I'll just reiterate it. We want to deconstruct myths that perpetuate HIV stigma. We want to support those people who are affected with HIV or people that may be living with HIV. And we achieve this by addressing our core values, which are awareness, assistance, advocacy, and alliances. Through awareness, such as the use of platforms as this to inform the public, we do have opportunities to inform healthcare providers and novice learners entering the public health community. We provide assistance to people who are affected by HIV, advocacy through policy influence, and we build alliances, such as our collaborations with other community organizations such as UNCW, the NAACP in New Hanover County, North Carolina AIDS Action Network, just to name a few. And that is just a few. But we are really grateful that we are able to address all of our pillars through our mission. So again, this is the pre-survey. The way that we can ask for funding and support, we want to demonstrate impact. So again, we want to make sure that when you leave here, you have an increased understanding and that we are able to change any misunderstanding that could perpetuate stigma for those who are living with HIV. So if you can, please do the survey and we will address it again at the end where you can retake the survey. Now, Michaela, I know, and this is sort of like a comic, relief. We're just going to sort of let down our hair a little bit. I just want to address sister and sister, okay? And this is on behalf of me. I'm not speaking for all Black people, but I do appreciate the title where we're talking about sisters in the South. And I just wanted you to know that when we're saying sister, I could be saying sister to not only a woman of color, I could be saying sister to you, Michaela, anyone of white descent, Latinx. And a sister can be my female friend. And when I claim someone as my sister, we have been transparent about our differences as well as our commonalities, but we've had the opportunity to sort of move beyond that. And we support each other in our purpose. But for today's purpose, we will highlight the sisters. And when I say the sisters, you will not hear me say you're going to hear me say sister. And I'm talking about women of Black and African descent with melanin in their skin. And because of the melanin in our skin, we actually bear the burden of all the isms, whether it is classism, sexism, or racism, but is the impact of those isms that society have placed upon us. And so this presentation, my heartfelt goes out to the sisters. I must do HIV 101. I don't want to assume that everyone that is with us today know the basic knowledge about HIV. But HIV stands for human immunodeficiency virus. AIDS stands for acquired immunity deficiency syndrome, which is the most advanced stage of HIV infection. They are not the same. Again, I want to reiterate that they are not the same. Because someone is living with HIV, it does not mean that they have AIDS. But again, if HIV goes untreated, there is an advanced stage of HIV infection where there is an acquired deficiency syndrome. No one dies of HIV. HIV attacks the CD4 cells of the immune system that we use to fight off infections and even some cancers, but the lack of treatment is what causes HIV to destroy our immune system that leads to the progression of AIDS. And then there's antiretroviral therapy, also known as ART, which is a combination of HIV infection medications. Again, a combination of HIV medications. So although HIV medications may be simplified to one pill, but is a combination of active ingredients in that regimen. So again, the combination of medications are used to treat but not cure HIV, and antiretroviral therapy reduces the viral load for someone who is living positive, and it prevents the HIV cells from multiplying. And then we have protection of our immune system and prevent the advancement of HIV to AIDS. There are some myths and facts that we need to address and get out the way. And this is really important for anyone who's taken the pre-survey and the post-survey. Hopefully you've already addressed the pre-survey. But the transmission of HIV, what we do know is that you cannot get HIV through shaking hands, hugging, kissing, contacting someone by sharing utensils, doorknobs, toilets, or blood-sucking insects. That is not how HIV is transmitted. HIV is transmitted through infected bodily fluids, blood, semen, pre-seminal fluid, which is quote unquote cum, pre-cum, vaginal fluids, rectal fluids, and breast milk. But in the US, HIV is usually spread through vaginal and anal sex without the use of a condom or without medications being present to prevent HIV, which is pre-exposure prophylaxis, and of course, someone who is on antiretroviral therapy. And we're going to talk about that a little later on. HIV is also shared through drug injection items such as needles. But again, it doesn't necessarily have to be needles. It could be sharing of works or any paraphernalia where any of those bodily fluids could be present, primarily blood I'm referring to. And then mother-to-child transmission can occur during pregnancy, childbirth, and breastfeeding. Heterosexual contact, meaning a woman and a man, is the risk factor for 85% of HIV transmitted infections among women. And again, the transmission of HIV from a HIV positive mother during pregnancy, labor, delivery, and breastfeeding is called mother-to-child transmission. Now, in the absence of any intervention, so if a mother is positive and she is not on medication, the transmission rate can range from 15 to 45%. But what we do know is that if a woman is HIV positive and she is on medication while she is carrying and her viral load becomes undetectable, it is less than a 1% opportunity of transmission to her child. And that's really, really important. So let's just look at some information just so we can get a global perspective about the HIV in its pandemic sense. In 2019, there were approximately 38 million people across the globe that were living with HIV. The majority of these people are in lower income countries, which are in West and South Africa. There were estimated 1.7 new infections worldwide. And although there have been progress in decreased rates for new HIV infections overall between 2010 and 2016, what we do know is that there's been unequal progress for vulnerable populations. And this is primarily due to stigma, discrimination, social inequities, and exclusion. And this is why we're having this conversation. And again, the group of Black and African American women are a part of the vulnerable populations that we will be discussing. Now, when we look at the United States, in 2019, there were 1.1 million people in our nation who actually were living with HIV, but only 86% of those actually knew that they had HIV. That means they had a test and they received their information and they have been diagnosed. Only 64% actually received care. That means they were linked to care, they came in contact with a provider so that they could receive treatment. Well, out of those, only 49% actually have been retained in care, and only 53% are actually virally suppressed. So I want to just make sure people understand what virally suppressed means. So if you are HIV positive, um, as a clinician, we follow your viral load. But once you start medication and you are treated effectively, consistently taking your medication every day, virally suppressed, your virus becomes undetectable. Undetectable. And although you are undetectable for the virus, um, you will always test positive for HIV. However, the virus is not replicating in your system so that it is then transmitted. You guys with me? All right. So let's talk about what brings us here together. In 2018, Black and African American women actually comprise 64% of all new HIV infections for women overall. So 17 and 19% HIV infections were among white and Hispanic women, respectively. But what does that actually mean? All right, so when we take a look at it, Black and African American people only make up about 12% of the US population, and only 50% of those are actually women. So that means that women in the US, Black women only comprise maybe 6.5% of the US population. But when it comes to HIV infections, this is where the disparity lies. We comprise 64% of all new HIV infections. And then when it comes to perinatal transmission from a mother to child, 65% of those perinatal transmissions were of Black and African American women. 14 and 9% were among white and Hispanic women, respectively. Now, fast forward, this is some information that I received from the Southern AIDS Strategy Initiative, and it highlights HIV among Black and African American women in the Deep South. And when I'm referring to the Deep South, I'm talking about Alabama, Florida, Georgia, Louisiana, Mississippi, the Carolinas, Tennessee, and Texas. There is a particularly high burden of HIV infection among Black and African American women. As you see, the diagnosis rate for Black and African American women in the Deep South was 28.5, while it was 2.5 per 100,000 our counterparts. So this is the huge, huge disparity. And then come along 2020. When come along 2020, now we have the COVID-19 pandemic. And these numbers I actually looked up yesterday, but when I turned on the news this morning, it seemed like things had actually changed. And what we know is that there have been 7.48 million cases of COVID, about 211,000 deaths in the US, and there are higher rates of infection among people who are non-elderly. And then when it comes to the elderly, there are higher rates of death, but particularly vulnerability and poor health outcomes for men, people with underlying conditions, and persons of color. This is what we do know about COVID-19. Now, just to, I can't even say, give you some good news, right? Because COVID-19 is not good news. But to sort of neutralize what COVID-19, the impact that it has had in regards to infection on people living with HIV, I want to share that there's been no evidence that persons living with HIV are at an increased risk of COVID-19 infection or a related death. Okay, so you can't separate the difference about what causes death, any confounders related to COVID-19. When a person has COVID-19, they're HIV positive, they're a person of color, they have an underlying condition, and they are of a lower socioeconomic status. So when you have all of those confounders, which actually characterize the majority of people who are living with HIV when it comes to people of color, underlying conditions, and low socioeconomic status, there's no evidence that the risk for COVID-19 infection is greater for those people who are positive. Now, we've had the opportunity, my colleagues and myself, doctors Longmar Avatal and Dave Grady, we did a brief anonymous mixed survey. And this survey was shared with women who are HIV positive. We recruited these women from listservs on social media platforms, and they included women who also clients of Seeds of Healing. And the average age of the women were about 45. The majority came from Georgia and Carolinas. And we were happy to learn that during the COVID-19, as well as the racial trauma that we are experiencing in our nation, the majority of women said that they were missing a lot of doses of their medication. However, their feelings of loneliness and fatigue, specific to being Black, being an HIV positive woman, there was a demonstration of a strong relation to those two things, loneliness as well as fatigue. In addition, women expressed fear, and what they shared was that they began to self-isolate because research has demonstrated that 1 out of 3 African Americans and people of color actually know someone who has been affected and actually died from COVID-19. So as the rates of death increase, women who are living positive and who are Black and African American, they had a mounting fear because their friends and their family and their coworkers were being diagnosed. They were battling concerns about income, loss of wages, and this created a fear and a burden that they experienced regarding COVID-19. Now, when we talk about what has all happened recently in our nation, COVID-19 came, and then there was an explosion of racial injustice and violence, especially with the George Floyd incident. And it highlighted the burdens and the barriers that actually perpetuate why Black women are at increased risk of HIV. And what we understand is that the socioeconomic factors that are influenced by poverty, racial discrimination, lack of access to health care, higher rates of incarceration for our men, which actually disrupt our social network and the availability of healthy relationships that we have. This is what perpetuates the risk factors for HIV among African American women. And then there's stigma. So the stigma that actually occur around disclosing risk factors or even sexual orientation. We do know that there is a high incidence of HIV among men of color, whether you're Black or Latinx, who have men who have sex with men. And if someone is not comfortable with disclosing the sexual orientation, they may create or participate in a lifestyle that is truly not theirs and actually put women or someone else at risk that they intentionally, they did not mean to do. But the fear of disclosing risk behaviors, sexual orientation can prevent people from seeking testing. It prevents access to treatment services, support for friends and family, and as a result, African Americans lack information on HIV prevention. So stigma surrounding HIV and AIDS can include, but is certainly not limited to, believing that only certain groups of people have HIV. So if you are a Black woman and you only think men who have sex with men are at risk for HIV, you've done yourself an injustice, right? Because HIV does not discriminate. But making moral judgments about people who also take steps to prevent HIV, such as having access to PrEP, pre-exposure prophylaxis, can also be a barrier to ending the epidemic. And feeling that people deserve to get HIV because of their choices is also a risk factor, whether or not you believe it or not. And receiving poor treatment in healthcare. Discriminatory behaviors when someone accesses healthcare can also be a barrier because people will not go get screened, people will not return to the healthcare provider for treatment. And being shunned by family members and peers in the community are also circumstances that perpetuate stigma that has been associated with the lower or delayed access to care due to perceived discrimination um, related to being HIV positive. Now, I do want to share um, some of the facts that we know about vulnerabilities. So, why prevention is a challenge. One in 9 women actually know that they are a positive, HIV positive, right? And then the anatomy of a woman, receptive sex is riskier than insertive sex. So there's a higher chance that a woman would actually contract HIV if she's having unprotected intercourse. And women who have been sexually abused may be more likely than women who have not to engage in risky behaviors. So there are higher rates of sexually transmitted infection among Black and African Americans. And so, what we do understand about this high HIV prevalence, there's greater exposure. I shared the numbers with you earlier. So, the chances of running into HIV, if you are not protecting yourself and preventing HIV, there's a high risk for infection. Having lack of knowledge, no screening, no access to screening. In New Hanover County, there is minimal community screening. So if someone wants to be screened for HIV, most times it's because they have advanced disease and they're symptomatic, or it's through contact tracing. But we do encourage that all primary care providers are screening their clients between the ages of 13 and 65. Everyone should actually know their HIV status. Having inadequate condom use. But reports have demonstrated that 93% of HIV negative women reported having vaginal sex without a condom in the previous year, and 26% reported having anal sex without a condom. Those are high risk behaviors. But fewer people with HIV are aware that they have HIV compared to other regions in the US. But I want to make sure that everyone knows that more than 50% of all new HIV infections actually have occurred in the Southeast United States. Again, more than 50% of all new HIV infections have occurred in the Southeast. But fewer people with HIV in the Southeast actually receive timely medical care, especially those who live in remote areas who do not have access to transportation or providers who are knowledgeable on HIV care. Or you may have providers that have a limited perception in regards to who is at risk. So screening doesn't occur. There's limited uptake in the South on PrEP, pre-exposure prophylaxis. So Southerners account for about 27% of the use of PrEP, although we have such a high risk of new infections. And lastly, women who have been sexually abused may be more likely than women to not engage in risk. Let me say that again. Women who have been sexually abused may be more likely than women who have not to engage in risky behaviors such as exchanging sex for drugs, having multiple sex partners, or sex without protection, such as using condoms or taking medications to prevent HIV. So I want you to just consider these actions. These are steps that we can do to assure that we are all working together to reduce and to prevent and end the HIV epidemic. We want to make sure that we are using language that is supportive and not any negative connotations. So earlier I talked about understanding that because someone is HIV positive, that does not mean that they have AIDS. HIV positive does not have a look. If someone is HIV positive, it does not mean that they are going to have a poor outcome, because people who are positive can live a healthy life and they look just as healthy as you and I, especially if they have access to care. We want to emphasize the rights and protect the privacy of people that are living with HIV and reduce barriers to prevention and treatment services. And those are things that we can do to prevent stigma, to reduce stigma. We want everyone to have access to testing. Again, all providers should be testing their clients between the ages of 13 and 65, whether they say they are sexually active, sharing needles, or using illicit drugs or not. Of course, we want to encourage abstinence if people are not in healthy relationships or married and giving consent. So that means to just abstain from sexual activity until you're responsible enough, appropriate condom use. And for anyone who is diagnosed with HIV, we want everyone to have access to antiretroviral therapy. And we want to reiterate that the U equals U. So the U equals U campaign is undetectable means untransmittable. And what does that mean? If someone is HIV positive and they're on medication and they have an undetectable viral load, they will not transmit the HIV infection to someone else. And this is why we really encourage anyone that happens to be living with HIV, we want everyone to have access to care, right? Because once they become undetectable, and I use the example of a mother who's carrying a baby. For a mom who's carrying a baby, how much more at risk can you get when you're sharing the secretions and the blood and the bodily fluids with your child? But if you are on treatment and you are undetectable, it's untransmittable. So again, U equals U. Undetectable is untransmittable. Everyone who is living positive should have access to care and access to antiretroviral therapy so that they will be undetectable. And PrEP. PrEP is pre-exposure prophylaxis. And PrEP is a pill that can be taken once a day for someone who may engage in risky sexual behaviors. They may not be in a committed relationship. And if this is taken every day, we want you to know that the people who we would encourage PrEP use for is people who their sexual partner is possibly HIV positive. Again, someone who do not know the status of their partner, or again, engaging in sexual behaviors. PrEP is available through Medicaid. It is available through private insurances as well. And let me see, PEP. There is PEP. A lot of people do not know about PEP. So post-exposure prophylaxis. Post-exposure prophylaxis, I knew about it as a healthcare worker because as a nurse working, if I was exposed to HIV through a needle stick exposure, for instance, I can go to employee services. And if we do not know the HIV status of my patient, I'm offered PEP, right? I'm offered PEP regardless. Post-exposure prophylaxis, which is taken up into 72 hours of possible exposure. And this is offered to if someone is sexually assaulted and they go to their primary care provider or an emergency room, you can actually be offered PEP. You should be offered PEP until your testing has been completed and you know that you have not converted to HIV if you were actually exposed to it. And PEP is not available right now, like over the counter. However, there is some policy influence that is going on where they are encouraging PEP, pre-exposure, post-exposure prophylaxis through pharmaceutical services. And more information is to come for that in the future. And then we have North Carolina HIV disclosure laws, which assure that there's not over criminalization for people who are actually living with HIV. And so the disclosure laws, what they actually do is it there's a perception that people who do not disclose their status, that they are keeping something secret. And it actually can be a barrier, right? Because if people think that they're at risk of people finding out their status because they go to the doctor or maybe they have a medication bottle, it actually prevents people from seeking care because they do become secret. But people should be allowed the opportunity to be private. And what the North Carolina HIV disclosure law does, it says that a person living with HIV must disclose their status to future partners unless they have been virally suppressed for at least 6 months or they are a victim of sexual assault. And so persons living with HIV are generally prohibited from engaging in condomless sexual intercourse unless these exceptions apply. And they are, number one, the person is in care. The person living with HIV is in care, adherent with their treatment plan by their attending physician, and they have been virally suppressed for at least 6 months at the time of intercourse. Number two, the person living with HIV sexual partner is also HIV positive. Number three, the person living with HIV sexual partner is taking pre-exposure prophylaxis, which is PrEP, as prescribed by the attending physician. And number four, the sexual intercourse occurred as part of a sexual assault in which persons living with HIV was the victim. So that was a mouthful. If you want to interject, Dr. Howes, let me know. Okay, so just to share some of the advocacy work that have been done around HIV and policy. Policy is one of the strategies. So this is a tool in the toolbox. We've already talked about being abstinent, using condoms, being undetectable, using PrEP, using post-exposure prophylaxis, making sure that people who are HIV positive are not over-criminalized for living a healthy and productive life the best way they can. Well, policy is also a tool in the toolbox. And due to the advocacy work that has been done in North Carolina, I want to give huge credit to North Carolina AIDS Action Network. There's been several strides. One, we have the North Carolina disclosure laws. Overall, as a nation, we know that the LGBT rights have been protected and we have access to health care. And in North Carolina, in 2016, there were premium assistance that was provided to people with low income. So those who are living positive, who had low income between the 100, making between 100 and 300% of the federal poverty level, they actually could get premium assistance to pay for their conventional health care. And now in 2021, the North Carolina Department of Health and Human Services has lifted the income restrictions. And there's still work. There's still work. And so I put healthcare access for all because we're talking about people living with HIV, but there's still a huge burden of people who do not have access to healthcare. And these are the people that live in the death gap. They call it the Medicaid gap, but another term for it is actually the death gap. And these people who are not poor enough to get Medicaid, but don't make enough money to actually pay the premiums for conventional Medicare, medical access, health insurance. So there's still work to be done. So there's been some strategies that Seeds of Healing we have addressed during the COVID-19, and there's been some trends that we do know about Black and African American women. And because of their social isolation, we've taken on a task. So what we do know is that Black and African American women are more likely compared to other racial groups to seek out resources for sexually transmitted infections online. Black and African American women, the sisters are using the internet as a primary source for research and recruit. Well, they are being recruited. The internet is using the internet is being used by researchers to recruit Black and African American women for research. And then there's a reliance on internet for health information and support that actually may perpetuate the bias that sisters are likely to encounter from the healthcare systems. And so what we do know that this is a timely opportunity for us to create platforms where sisters can actually receive credible information from trusted sources that is comprehensive and culturally relevant. And with that, what we have done is we are creating a platform. And the platform is, again, which I mentioned earlier, is So Time, which is a virtual support for Black women who are living positively. And there is an opportunity if you want to take part, you can actually be a content contributor, and the content contributor is for experts who work in mental health, medication management, mind body connection, physical activity, and nutrition. And you can actually apply to be on the platform. We are primarily seeking other sisters who look like the people who we are serving. And so hopefully, our supporters are putting this information in the chat box for you so that you can learn more about it. And if you want to contribute to this initiative, you can do so. In our region, there are several resources. We have case management agencies through Bridges, LLC, Partners in Caring. HIV screening can be obtained through Coastal Horizons, the New Hanover County Public Health Department. You have to go there. Previously, there were screening opportunities in the community, but that have changed, and that was even before COVID-19. But you can actually go to the Public Health Department to get tested for HIV. Planned Parenthood, Wilmington Health Access for Teens, which is also known as the WET Clinic, and then to receive care, New Hanover Regional Medical Center actually provides care. There's also care provided by local infectious disease practices in the community as well. And I do want to highlight some of the resources that Seeds of Healing have been able to provide during COVID-19 for the community, and through our collaborations with other organizations. We've been able to provide face coverings and sanitizers, laundry assistance for people who need to wash their clothes at a laundromat, nutrition services, menstrual hygiene products, and actually providing Uber health rides to people who cannot access healthcare during COVID-19 who are living positive. And we have a few upcoming events. We have Seeds of Healing self-care strategies during COVID-19, which will be available on our website within the next couple of weeks. And that is for the community at large, not just people who are living with HIV. We have the So Time virtual platform, which I previously mentioned. And then every year for the past 3 years now, we will have the Red Ribbon event, but this year we will actually have a virtual occasion. I want to share with you our website. If you want to follow our events and get involved with Seeds of Healing, you can visit our website. The information is there, as well as our email address. This information is in the chat box, but the website is seedsofhealinginc.org, and our email is info@seedsofhealinginc.org. And for anyone who had the opportunity to do the pre-survey, this is the opportunity for you now to do the post-survey to see whether or not your knowledge about HIV has changed, increased, and if there was any perception that you had that may have impacted HIV stigma, whether or not those beliefs have changed. So we ask that not only you do the post-survey for today's presentation, but then you also take the opportunity to do a satisfaction survey on our discussion today, and maybe you want to give some feedback about the content. So as we develop these opportunities to share HIV awareness with the community, we can make sure that we are giving the community exactly what they need. And thank you.
Thank you so much. So we have time for questions, so please feel free to add those into the chat. Dr. Wallace, one of the things that I find so intriguing about your work is that you really do tie in the cultural, so with the biological. So it's not just, okay, we are treating the disease, but we are really, looking at the person, and not just the person, but what their actual lived experiences are like, right?
Yes.
And can you talk, I mean, your whole presentation is is effectively a discussion on that. But could you talk about, especially since we have these a lot of people interested in pursuing health careers or working with people in healthcare. Can you talk about why it's so important to really understand how the cultural competence with the group that you are working with and serving?
Well, cultural competence. So that can be an array, right? So we're talking about race, we're talking about sexual orientation, we're talking about religion. As a Black woman, I know my experience when I engage with healthcare can be impacted with who's caring for me, how they're treating me, and what they perceive to be a value to
Mhm.
me.
Mhm.
So, as a Black woman raised with spirituality being a priority for healing, right?
Mhm.
If my health provider don't understand that or cannot value that or do not see that as a priority, it can actually impact my health. And I will use the example, for instance, there was an opportunity where I was taking care of a young woman who presented with vaginal symptoms recurrently. And I had the opportunity to look at her chart and I said, you're not, your viral load is high. Your viral load is high. You're going to have vaginal symptoms if you're not treating the virus. That's an outcome. And what the sister told me was, well, she started to cry. And I said, well, why are you crying? What is going on? Why are you not, and she said, well, she's not taking the HIV medicine. Why are you not taking the HIV medicine? And she said that if she took the medicine, then she was not believing in God's miracle to cure her. Right now, being raised in a household of spirituality, belief in God, and also having my own experiences where my mother only relied on faith for her healing, I could appreciate that. And it was an opportunity for me to tell her, well, you showed up with these vaginal symptoms. You want a pill for that. Don't you believe that God is going to give you a pill for the virus as well? But if I could not appreciate why that was a priority, some people, and not everyone, some people may not take advantage of that opportunity to, you know, dig in, develop a rapport,
Mhm.
and open up this opportunity to get her to become adherent with her medication. Or if someone does not, say for instance, someone is a non-believer,
Mhm.
right? And if their value supersedes the person that they're taking care of, that's a missed opportunity to save a life. So having competency in putting the client's needs, beliefs, and values first over your own, and putting yourself to the side and humbling yourself, it can actually save a life.
Okay, fantastic. And it's we see that in Samoa. I work in the South Pacific and working
Mhm.
in prenatal care there. There are women who don't get prenatal care until the very end or not at all. And part of the reason they'll say is, oh well, because it's basically saying that I don't believe in God or I don't trust God to
Mhm.
take care of me. And again, if a provider is dismissive of that, we lose an opportunity,
Yes.
potentially to be able to support them in a way or to be able to work within the community in a way that's meaningful, to be able to ensure that these women do get the care that they need, right? So it's
Yes.
certainly a global phenomenon, a cross-cultural challenge that's critical. We've got a couple questions here. Georgina asks, she said that she says that you said that there's no evidence that those with HIV are at higher risk of COVID, but if HIV attacks the immune system, wouldn't that put them at a higher risk? Is it possible that there's no evidence for them being at higher risk because there's not enough research yet?
No, this is what I will tell you. If someone is immunocompromised, someone could be immunocompromised because they have an organ transplant recipient. Someone could be immunocompromised, maybe they're undergoing cancer treatment.
Mhm.
Someone could be immunocompromised because they are on prolonged use of steroids because they have lupus. Anything that makes you immunocompromised is going to make you vulnerable to a secondary infection, such as COVID. But I want to reiterate that someone that is on HIV treatment and they're living a productive and healthy life, taking their medication consistently, and they're out the woods of those poor health outcomes, there has been no evidence that their risk of acquiring COVID-19 is greater than the general population. But what I do want to share, for someone that is immunocompromised, there is a chance that they may not mount a response to COVID-19. They may not get a cough, they may not get a fever, and they may have COVID-19 infection, but when their immune system is compromised, they don't get that response. And so that risk factor is heightened for not only themselves, but for those who may be in their presence.
Wow, that's a really powerful thing for us to all keep in mind. Thank you. Friend Sean adds, as a Native and African-American woman, when I go to medical providers, I am more sensitive to dismissive nonverbals that white providers often show. As a medical health professional, I realize that it's more about their lacking, but as a human, I feel unseen and unimportant. And again, this is why this work and this discussion is so important for us to keep that at the forefront. We can treat the biology, we can treat it, but we're not treating the person if we're just focusing on the disease.
Yeah.
Shay adds, how would you recommend conservative religious institutions address the stigma of HIV and sex in general?
Well, you know what? I appreciate that question. I am fortunate to be a member of New Beginnings Christian Church. And my pastor, Pastor Robert L. Campbell, has actually allowed not only me, but as a pastor, he has used that platform to talk about faith and to talk about being compassionate to those who are living positive, but also sharing knowledge about HIV, not shunning those who have a different sexual orientation that are perceived to be at a higher risk. And he has hit those things nail on. And if anyone visit our website, you can actually hear some powerful words from Pastor L. Campbell. But that's what they need to do. They need to address it from the pulpit as opposed to shunning circumstances that are deemed to be morally judged. Morally judged. Someone who is not married and may be involved in sexual activity or have a different sexual orientation. That moral judgment can actually isolate people and actually prevent them from seeking care and treatment and saving their life.
Thank you. Could you talk a little bit more? I mean, you referred to pieces of it as we went through. Could you talk a little bit more about some of the barriers that people might face as they're trying to achieve care? I know globally, we still have a high percentage of people who are not on medication. And so you're welcome to speak at a global perspective or local or both about why might it be a challenge for people to get access to these life-saving medications?
Yeah. So I'm going to keep it local, right? I'm not a global health expert. Again, we can reiterate. For one, I know locally having access to providers who have a specialty in HIV care. Right here in the Southeast region of North Carolina, New Hanover Regional Medical Center is the largest HIV provider, right? In that region, they have 3 HIV providers in their staff. And I'm talking about the Southeast region. So that's New Hanover County and the surrounding counties. That's like a 6 to 7 to 8 county platform. But they only have about 3 specialists. Now, that doesn't include a few infectious disease providers that have a small percentage of people that they care for who have insurance. We're talking about a provider that New Hanover Regional is caring for people that are uninsured or underinsured, people that are marginalized, that fall in that gap of not having health insurance, people that live in remote areas who tend not to have transportation. And that clinic, the clinic at New Hanover Regional, they actually travel to remote areas to take care of people who do not have access. So that is a local picture. And what we do know is that over 1 million people in North Carolina who do not have access to health insurance are non-elderly. And non-elderly folks, young adults, are actually in that gap of people who make up a majority of new HIV infections.
Oh, wow. you for that. So Dr. Susie Diggle, who's past New York State HIV Department of Health scholar, she asks, what are we, and she puts in parentheses, white healthcare providers missing? Thank you. We need to know.
Yeah. What are you missing? I work with white health providers, and I take off my hat to my colleagues because they do their best. But again, that piece about cultural competence, not understanding or appreciating and being transparent about our differences, right? And only, maybe acknowledging those things that make us the same. But people of color, I'll say that from my experience, I want to see someone who looks like me, who understands my dialect, who understands my challenges, that although they can be challenges of other races, but they predominantly affect my whole family generationally. Being a single mother, having to work 2 to 3 jobs and not being able to show up 15 minutes early for this appointment. And I just got here one time at 3 o'clock and you wanted me here at 3:15. So now you won't see me. Understanding what is it like to possibly have um, low income and no insurance, and having pride and not wanting to ask for support because you need a voucher to pick up a medication that you greatly need, but just taking that discomfort of barriers, pride and humility off the table. That is sometimes what white providers are not getting. And so when you have someone that is not just of color, because blacks are not always the experts on blacks, but I'll use myself, for instance. I have humble beginnings. I've been on Medicaid. I've stood in line for cheese. I've lived in subsidized housing. I've come from a single parent household. But when you have someone that can identify with the people that you are taking care of, you know, you drop all of that at the door and you can, have mountains among mountains move when you walk into the room to take care of somebody that you can identify with. So I would encourage you to bring people in your practice that represent the populations that you're taking care of. And don't try to just be the quote unquote great white hope, because you can't do it yourself.
Wonderful. So we have just a couple minutes here left, and I want to give you an opportunity if there's anything that Dr. Wallace that you want to share, that you want to conclude with. We did share the links that you provided throughout in the chat. We recommend everyone go and check out Seeds of Healing, and I urge that if you've got extra change in your pocket to also kick it their way, because they do excellent work for our community. But Dr. Wallace, do you have any closing thoughts that you'd like to share?
Closing thoughts. I have to just drive the understanding for compassion. Um, there's a saying, but for the grace of God, there goes I. And you never know who you're near that may be living with HIV or a condition or affected by HIV. But saying things that are unkind and making judgments is actually some of the things that perpetuate why we continue to have increased risk infections. And I would just say, have these conversations with your family, your children, your community about safe sex practices, because not having a conversation and a perception that is not happening, I'm sorry to tell you that you're better off to make sure that they have all the tools in the toolbox, including abstinence, but actually acknowledging access to resources, people understanding their risk. Knowledge is power, and do not underestimate it. And again, to be kind and to be compassionate.
Wonderful. Thank you so much. Those powerful words to end on. So we have the post survey. Please take a moment and complete that. So again, this is part of the way that Seeds of Healing is able to continue accessing funding. We'd love to thank Dr. LeShonda Wallace for joining us today. And to those of you who connected with us, we ask you to please consider following the Honors College and UNCW Department of Anthropology, History, Biology, our social media for upcoming events. Next in our series, in the Pandemics Exposed lecture series, October 29th at noon, we're having the evolution of SARS and CoV-2 during the COVID-19 pandemic. Again, we'll have more information on that coming soon if you follow our different social media pages. And that's Dr. Troy Day, a professor of math at Queen's University. Again, we're trying to be as combine as many different departments and expertises to ask and answer these huge questions that are we have in life. Dr. Wallace, thank you so much for your time. Thank you to all of you who joined us today, and have a great week.
Thank you. Thank you for having us. Bye-bye.